All right, to all who are new here, my name is Dr. Michelle Henney, and I'd like to welcome you to Relevate Sports Medicine's Virtual Journal Club. Thank you for joining us this morning. For additional webinar educational opportunities, you can visit our website and register directly for the webinar or sign up for the email list to be notified of upcoming webinars. We are continuing to update our schedule, so check back often. This video will be available for review after this journal club. The information contained in the video content represents the views and opinions of the presenters and does not necessarily represent the views or opinions of Relevate Sports Medicine. The mere appearance of video content on the website does not constitute an endorsement by RSM or its affiliates of such video content. The video content has been made available for informational and educational purposes only. The video content is not intended to be a substitute for professional medical advice, diagnosis, or treatment. Always seek the advice of your physician or other qualified healthcare provider with any questions you may have regarding a medical condition. Never disregard professional medical advice or delay in seeking it because of something you have read or seen on the site. RSM hereby disclaims any and all liability to any party for any direct, indirect, implied, punitive, special, incidental, or other consequential damages arising directly or indirectly from any use of the video content, which is provided as is and without warranties. For all athletic trainers who are intending to get live CEUs from the BOC, you will receive an email 1 hour after the webinar concludes, which includes a link to the combined quiz evaluation and assessment. You will have up to 72 hours to complete the quiz and the evaluation. This email will come from customer care at gotowebinar.com. Please ensure that this is done to receive your statement of credit. If you don't receive a follow-up email or you have any other concerns, then contact us via our email at journalclub@relevancesportsmedicine.com. Once the statement of credit is available for download from our website, you will receive an email notification. If you have any questions during the webinar, please submit the question and we will review questions at the conclusion of the presentation. If you cannot see the PowerPoint slides and you're accessing the webinar from your mobile phone, swipe the screen to the left or to the right and the slides will become visible. The recording will be available for review from our website. Dr. Justin Mullner is a board-certified primary care sports medicine physician with the Orlando Health Jewett Orthopedic Institute. Caring for adult and pediatric patients, he advises athletes and others with physically active lifestyles about optimum ways of recovering from injury, preventing injuries, and improving performance within the context of their overall health and wellness. For those who experience injury, he provides the most up-to-date and effective treatments. Dr. Mullner earned his medical degree and completed his internship and residency in family medicine at the University of South Carolina School of Medicine in Columbia, South Carolina. He then completed a fellowship in sports medicine at Atlantic Health System in Morristown, New Jersey. Dr. Mullner is currently the head primary care sports physician for Orlando City Soccer Club and Orlando Pride, and he'll be speaking today on groin pain in athletes.
Great. Thank you very much. I'll take it away here. So this morning, I'm going to talk to you all about a topic that I really have taken a lot of interest in throughout my career, and especially here in Orlando as I take care of all the soccer teams here, not only the pro team, first team levels, but also all the way down through the academies. So we're going to talk today about groin pain in athletes. So first of all, just as introduction, we'll talk about definitions, anatomy, terminology, and treatment. These are all athletes that are relatively high profile that have suffered from what's now being termed groin pain in athletes. You may recognize Adrian Peterson, Odell Beckham Jr., Jermaine Jones, and then this is our own Joao Moutinho, who is no longer with Orlando City, but had a lot of issues with groin pain. So you've all probably heard the term sports hernia. So this term is falling out of favor, but it's still generally understood by the public and by your patients. And people will come in and say, I have a sports hernia, or I think I have a sports hernia. What do you think? And it's defined generally as a strain or tear of any soft tissue, muscle, tendon, or ligament in the lower abdomen or groin area. It's a pretty non-specific definition. The lower abdomen and groin covers a lot of territory, a lot of separate anatomical structures. So that's part of the difficulty in understanding what this means, and part of what we are trying to address with some changes in terminology. So these are just a couple of examples of various different things that are all referring to essentially the same underlying condition: Gilmore's groin, inguinal disruption, athletic pubalgia, osteitis pubis. These are all ones I'm sure you've heard, and they all are. describing similar things. There is some, osteitis pubis is obviously referring more to the pubic symphysis. Inguinal disruptions, obviously more referring to the inguinal region, inguinal ligament region. But there's a lot of overlap in all of these things. Urban Dictionary, I like this definition probably more than all the other ones. If someone has a sports hernia, it means they're going balls to the wall. So I think that's probably just as good of a definition as any of the other ones. So this is just a slide that's very busy, but just gives you an example of how broad the differential diagnosis is here. Hip and groin pathology is very common in sports, but especially soccer, which is near and dear to my heart. But the hip is a very different structure compared to the knee or the ankle. With the knee and ankle, if the pain's down in the knee area, it's probably coming from the knee. If it's down the ankle foot area, it's probably coming from the ankle foot. But if it's coming from the hip, it could be the hip joint, but there's a whole host of other various different structures that can potentially be the source of the pain, and it's difficult to tell the difference. So this is just a quick review to show you some of the various different anatomical structures of the area. This is a picture of, or a couple different views of the bony anatomy of the pelvis itself. This is just a reference for you to look at before we get into the meat of things. The muscular anatomy is pictured here. Depending on the nature of the forces in the imbalance itself that's leading to the groin pain, various different structures can become overloaded and eventually break down, which ultimately leads to a number of different underlying causes of groin pain. I like these diagrams because they give you a little bit of a force vector for all the different directions of force on the same bony anatomy. So you've got your rectus abdominis muscles pulling upwards, you've got your adductors pulling downwards and laterally against each other, and that's where a lot of the underlying pathology comes into play. If you look at the picture on the bottom right with the red arrows, that kind of shows you the confluence of the rectus femoris and adductor tendons, and that is an important piece of the anatomy to this entire puzzle here. So here's just the ligamentous anatomy to give you a sense from a couple of different angles what the inguinal ligament itself looks like. It runs from the ASIS on the top of the pelvis laterally over to the pubic symphysis, and your abdominal oblique muscles essentially become confluent at the bottom and wrap around themselves to become the inguinal ligament. So it's anatomically dangerous site, and where a lot of things can go wrong. Your big femoral vessels and nerves run directly underneath it, and there are some nerves and vessels that run through the ligament itself, which we'll cover it a little later. So now, or I say now, but I've been giving this talk or some variation of this talk for over 10 years now. But back in November 2014, they had a big meeting in Doha, Qatar, that brought together all the big minds in, quote, sports hernia management. So Muskovec, Philippon, Holmec, William Myers from Philadelphia, Bruckner and Kahn. So you probably recognize many of those names from a lot of the research papers you've read. But they all got together in Qatar and put together a consensus statement trying to better define groin pain. And so they decided upon the terminology groin pain in athletes as a way to encompass all the different types under one label, and to move away from the term sports hernia or all the other ones that we talked about earlier that ultimately end up being very confusing. A little less catchy, but definitely more specific. So ultimately what they decided within this paper is that they broke down groin pain in athletes into 7 different categories. So you've got adductor related, iliopsoas related, inguinal related, pubic related, hip related, other MSK cause, and non-MSK cause. So this picture here is from the actual paper itself, and it really highlights the different structures that are involved with each different type. part of the impetus for this terminology change is to try to define each individual type of groin pain rather than lumping it all underneath one. You know, sports hernia could kind of be any of those. And the sports hernia terminology I understand because, you know, that's generally the pain is in the area where you generally have a hernia. And it's descriptive. People understand that. But if you're trying to be more specific, this is ultimately, I think, a better way. And then once we are able to break it down into separate different types, that allows for us to really come up with treatment plans for individual different types of groin pain rather than just a one size fits all type of treatment plan for all of these, which are ultimately different underlying conditions. So move on to the next here. The first is adductor related groin pain, and what that involves, and this is directly from the paper, this is how they've defined it. You have adductor tenderness and pain on resisted adduction testing. And this could come from adductor enthesopathy, where the adductor muscles are irritating the attachment point on the pubic symphysis or the pubic bone. And this can be acute or chronic. You could have just a standard adductor tendinopathy or an adductor strain more acutely. Iliopsoas related groin pain is the next one. And this one's much more likely if there's pain on resisted hip flexion and or pain on stretching the hip flexors. Iliopsoas bursitis is often the cause of this one versus your snapping hip syndrome or external snapping hip from the iliopsoas. Next is inguinal related groin pain, and this is pain located in the inguinal canal region and also has tenderness of the inguinal canal without a palpable inguinal hernia. So one part of a physical examination that should be done when you're evaluating for athletic pubalgia or groin pain in athletes is an inguinal exam. I don't think it's something that many athletic trainers likely should do. It's something that typically is done more in a doctor's office setting, preferably with a chaperone. This condition is more likely if the pain is aggravated with resisted testing of the abdominal muscles or with Valsalva cough or sneeze. Next is your pubic related groin pain. And this is local tenderness of the pubic symphysis and the immediately adjacent bone. There are no resistance tests for this one that can correlate. Osteitis pubis and osteomyelitis of the pubic symphysis are both conditions that can cause pubic-related groin pain. And then you've got your hip-related. So this can actually be really, really difficult to distinguish from the others. It sometimes will have a locking sensation or a catching or clicking or giving way from the labrum being torn. This is often seen in the setting of FAI or femoroacetabular impingement, which we'll get into shortly. Injection therapy is actually often very much how you can diagnose this. So we'll do either just a ropivacaine injection or one with ropivacaine and steroid directly into the joint. This is something that a lot of primary care sports medicine doctors do, where you use an ultrasound and guide the needle into the joint capsule and then inject the medicine. And if you're doing it in somebody that's younger, typically you'll just use the ropivacaine to minimize toxicity to the joint. And you're essentially injecting it, and then you go and have them do something that would normally really bother their hip in about 30 minutes to an hour afterwards. And if their pain is significantly improved during that period, then it gives you a much higher accuracy in terms of the hip joint being the source of pain. And if you don't get relief, then it's not the hip joint. There's a physician here, a surgeon here, who does a lot of hip arthroscopies, and he won't even do the surgery unless they've had an injection that proves that the hip joint is the problem. That's how, I mean, this is a guy that's examined probably more hips than anyone in the world or close to it. And he still relies on the injection as his confirmation before he'll do a surgery. Next, this is just talking a little about femoroacetabular impingement. So you break it down into two different types. There's your pincer impingement and your cam impingement. If you look at the bottom left diagram here, you can see on the upper left-hand corner of that diagram the normal appearance of the hip. And then you go to the right of that, and you can see that cam morphology, which is, you think of a camshaft in a car, there's a little extra bony growth on the often anterior or superior neck of the femur. And the significance of that is when your leg and your hip are moved into internal rotation, that you get contact between that cam bump and the acetabulum itself, where the labrum is attached, and then you start to get some wear and ultimately tear of the labrum. Pincer morphology is where the actual bony overgrowth is on the side of the acetabulum, and so you've got this extra coverage or over coverage of the acetabulum, and typically a deeper socket, and you get the same type of problem in internal rotation, where you get contact between the femoral neck and the acetabulum, and there's often combined cam and pincer morphology. You with this can get decreased muscle strength and decreased task performance functionally, increase in impingement, decreased trunk functioning, decreased dynamic balance, alterations in your gait. Your fader test is the one that's really the go-to test for this, where you push their leg and their hip into full flexion, and then you internally rotate it, and you're essentially recreating that position of impingement. And if they're painful with that, that's a pretty good sign that that joint is the problem. But it still can be other things. If it's negative, you're much less likely to have the hip joint as the source of pain. Still not completely ruling it out, but that's part of moving the needle in your decision-making process. So next, here's just an example of cam morphology. On X-ray, we use this alpha angle as a way to measure the cam morphology itself. Just to go a little bit more into the terminology again here. If you're looking at the bump itself on X-ray, the preferred term is cam morphology, not cam lesion or cam impingement. And this is essentially saying that the actual physical bump itself is the morphology, and it does not yet become a cam lesion or impingement until they have symptoms. And it's a little bit of just semantics, but ultimately, when you're speaking to another physician or another provider, you sound like you know what you're talking about when you use the term cam morphology. It's similar to when somebody says ACL repair, and it's not actually repair, it's a reconstruction. And so it's kind of one of those things, oh, this guy knows what he's talking about, kind of thing. So cam morphology is the preferred term, and it's thought to be present in about 25% of the population, which seems really high to me. But 25 to 50% of men are thought to have it, and only about 0 to 10% of women. So much more prominent in men for whatever reason. There was a paper that I pulled that showed actually that 89% of athletes likely have at least some degree of cam morphology. In 88% of people, it's bilateral. Only 23% it's painful. And then 42% actually have a pincer as well. And so the alpha angle itself, I'll go into that a little bit. What we're doing is measuring, you put a circle around the femoral head, and then you draw a line right down the middle of the femoral neck, and then the other line out to where the bone leaves the circle, and that allows you to find the alpha angle. If it's more than 60, then there's presence of cam morphology. Generally, if it's above 78, it's absolutely going to be causing symptoms and is considered a pathologic cam deformity, which will progress to end-stage OA very quickly. But if you have a cam morphology, alpha angle like 60, 65, it doesn't necessarily mean you have any symptoms. So it's not something that necessarily lends itself to a proper screening test. And generally, the larger the alpha angle, the greater risk of hip OA down the line. So next is your pincer morphology. Again, pincer morphology is not a pathology, but pincer impingement or pincer lesion is the preferred term if there is true symptomatology. And so this is thought to be in about 25 to 34% of the population. This one is actually much more common in women than men. Isolated pincer morphology or severe pincer morphology are much more in females. This often develops during the adolescent growth spurt. Despite the high prevalence, isolated pincer morphology actually is an infrequent cause of hip pain, and only about 8% of surgical FAI cases. And then this angle that we measure for looking at pincer morphology is what's called the center edge angle. So this is the alpha angle we looked at in the done lateral view, but in the center edge angle, we're looking at the AP view. And it's looking at a line straight down through the center of the femoral head, and then another line out through the edge of the acetabulum there. And if that's greater than 40 degrees, it's considered a positive for pincer morphology. So next, just a little more about femoroacetabular impingement. This is a talk that I've given to physical therapists in the past, and I always kind of highlight this slide that there is no level 1 randomized controlled trial evidence supporting physical therapy in other non-surgical modalities as being effective at this point. Doesn't mean that it doesn't work, but we just haven't really proven that it does or does not work at this point. So, obviously you're not going right to surgery with these sorts of things, but I think that more cases likely should go to surgery than do. I'm not a surgeon, so I will not even claim to ever try to send anybody to surgery if I don't have to. But this is something that's recognized much more in Europe. And we had a physio come in from Europe. He'd been in the Premier League that worked with us at Orlando City, and we had some of our youth athletes coming up with this type of stuff. And I mean, he was just like, "Yeah, just send them over to the surgeon, get it done." And we were all just like, "What are you talking about? I'm not sending a 16-year-old kid over to get surgery for this." So their mindset is very much over there, just get the surgery done. And I think that's going on some of the evidence of the fact that there hasn't been really non-surgical management techniques that have been proven in large studies to actually work. And ultimately, people end up losing a season or 2 or 3, in the build-up trying to do conservative management, and then ultimately their career stalls and they, decide to go do something else. And so this is, something we're still looking at. Surgery here in the United States is not nearly as common for this sort of thing, but sometimes it's necessary to keep people going, and also to prevent later, problems with OA or osteoarthritis. Other MSK causes is our next slide here, number 6. This could be nerve entrapment, post-herniaplasty pain, referred pain, avulsion fractures. You'll see these apophysitis or avulsion fractures of the various different muscular attachments of the pelvis, your iliac crest where the abdominal muscles are attaching, your ASIS where the sartorius attaches, the IIS where the rectus femoris attaches, your greater trochanter, your ischial tuberosity, lesser trochanter. You'll see, I think I have a patient right now with almost all of these, separate patients, but these are things that are relatively common in soccer, just from overuse. This is another topic entirely, but so much overuse in youth sports these days, so you're seeing a lot of this kind of stuff. As far as nerve entrapments go, here's a variety of different nerves that supply sensation to the area around the hip joint and around the groin. So your iliohypogastric nerve, your ilioinguinal nerve, your genitofemoral nerve, obturator nerve, and perineal nerve. And this diagram shows you all the different nerve distributions to help you to narrow it down a little bit. And then as far as other non-musculoskeletal sources of pain, this is not an exhaustive list, but true hernias, nephrolithiasis or kidney stones, appendicitis, diverticulitis, UTI, prostatitis, GYN conditions, malignancy. These are all various different things that can cause groin pain. And so if your exam is not adding up or the imaging isn't adding up, you probably need to do further imaging and dive into this a little deeper, because there are a lot of other things that can cause pain here, as opposed to something like the knee or the foot and ankle. Just to give you a little bit of the general anatomy of the inguinal canal itself. This is essentially a ligamentous structure that conveys the spermatic cord in men. There is no spermatic cord in women, but there is essentially the round ligament of uterus, which is more important when women are pregnant. And then there's the ilioinguinal nerve. And then the superior wall of that canal is the transversalis fascia, the external oblique aponeurosis, and the internal oblique and transverse abdominis muscle. The inferior wall is the inguinal ligament itself. Posterior wall is the conjoint tendon, the transversalis fascia, and the deep inguinal ring. And then the anterior wall is the external oblique aponeurosis and the internal oblique and superficial inguinal ring. And so next, we'll show you a little MRI anatomy here. So there is a specific type of MRI study that best looks at this area. An MRI arthrogram is thought to be a better test to look at the hip joint and the labrum for femoroacetabular impingement, and then ultimately labral tears. Our radiologists here are sports trained, and they are confident with our machines that they can read it without an MRI arthrogram. So we actually do not do arthrograms in our institution for labral tears. They're able to see them absolutely fine on our even 3T and even 1.5T MRIs here. And they can see labral tears just as well as they need to without the dye. So I actually haven't ordered an arthrogram in years. And then as far as looking at the actual pubic symphysis and quote sports hernia, then there's a sports hernia protocol that you can put within the order. Typically, you'll order an MRI of the pelvis, and then it needs to be an MSK MRI rather than a just a general medicine MRI. And then you put sports hernia protocol, which adds these axial oblique imaging planes that really fully characterizes the pubic symphysis and the rectus abdominis attachment and the adductor attachment as well. Ultrasound, it's great for what it is, and it allows us to see the inguinal ligament itself. I do a lot of ultrasound. I don't have a whole lot of confidence in ultrasounding the inguinal ligament and actually being accurate in terms of diagnosing something. But this also allows you to look at the pubic symphysis itself to see if there might be some degenerative changes there. Sometimes you'll do a directed injection there as well with ultrasound guidance. And then the upper right pictures show you the adductor insertions. So you can actually get a really good view of the adductor muscles, their tendons, and then their ultimate insertion points, and see if there might be a little fluid that's built up behind one of them or some partial tears. But ultimately, an MRI is the gold standard. Going into more treatment at this point. So when it comes to conservative management, our goal is to optimize the loads of the hip joint, which means improving hip strength, trunk strength, functional and balance retraining, sport-specific retraining, range of motion optimization, education, showing them the position of impingement. Oftentimes, people don't think of themselves as going into internal rotation of their hip in regular sports usage. But if you just cut from one side, just a direct cut from one side to the other, if you do not have the adequate strength of your glute muscles and pelvic control, then your hip dives into internal rotation significantly. And so oftentimes I will actually demonstrate that position of impingement in the office. And I feel like it makes a connection with the athlete when they see that. They're like, oh, yeah, I can actually see that. And it gives them a better cue that they need to really strengthen those glutes and also really learn how to activate the glutes better. When it comes to strength training, you consider strength and power, but also endurance capacity. You want to try to replicate functional positions for their sport. You want to retrain both sides. This is often bilateral, and they're just, it's just presenting on one side. So really strengthening both sides and working on both sides is important. You really want to watch for overactivity in the hip flexors. Often people get shortened hip flexors from sitting a lot, and that can lead to some alterations in the balance of the pelvis. It can lead to glute inactivation, which then ultimately contributes to just greater imbalance and problems in this area. And then you want to try to avoid impingement positions. As far as function and balance goes, sport-specific training is important. We talked about a lot of these already, but optimizing range of motion is also important, not only around the hip joint, but also in the lumbar spine and around the pelvis as well. There's likely some contribution for pelvic floor physical therapy with this. Some pelvic floor problems can definitely contribute to some pain in this area. And so this is an area, I haven't seen a whole lot of research yet, but I hadn't done a deep dive lately as far as really working on the pelvic floor in the context of groin pain. But we have sent a lot of our athletes over, especially if we're getting frustrated and really not able to get the to the bottom of things. It's actually one of our one of our athletic trainers at Orlando City a couple years back did a deep dive on some treatment methods for this, and he actually went and did a whole class with a thing called the Postural Research Institute, and he went and did this entire class and got this certification on dealing with this sort of thing, and he had a lot of interesting methods when he came back from that course, where he was having people in this wall sit position and blowing up a balloon at the same time. So, working on diaphragm control and pelvic control and things. So I think there's probably something to that, though there hasn't been a ton of research in that area. Another big one that's emerged since the Doha Qatar conference has been the Copenhagen adductor exercise. So there's a whole group of papers about this that really demonstrates it well and has some pretty good data. Think of it similar to how you think about a Nordic hamstring in terms of just building strength of the adductors. It's essentially like a side plank, as you can see in this picture here. And there's a lot of variations of this that you can find that is looking to work on eccentric and isometric loading of the hip adductors, primarily targeting adductor longus, which is the typical injury site for adductor-related groin pain, and used in prevention and rehab of the groin. Essentially, it's, like I said, side plank. And you can do it on a bench, you can do it with another person, and then that inferior leg moves into adduction. So you move it down up from the ground up towards your stable leg on top, and then you're trying to really maintain neutral spine and pelvic control. This is something that really takes some demonstration. It isn't something that you can just give a picture to an athlete and say, go do this at home. It's something that you really need to demonstrate for them and really put them through it, have them do it, show them what the proper positioning is, show them what neutral spine and pelvic control looks like, so that they can, it's not to say they can't do it at home, but they need to be shown how to do it properly. And as far as clinical relevance, it improves adductor strength and load tolerance. It restores this adductor-abductor strength balance. You always hear about the quad hamstring ratio. Well, there's also an adductor-abductor ratio as well. I don't think it's as well clinically defined, but also something to think about. It does decrease the risk of adductor-related groin injury. And there is progressions as well, which I won't go into much. As far as education, we talked about that position of impingement. You just technically just assume that FAI patients have early hip OA and treat it as such. Weight loss is important. So, an athlete that maybe has a couple extra pounds, if they could shed those pounds, actually helps with the forces that go through the joint. Sometimes you just need to find a sport or activity that they enjoy that puts them less into that position of impingement. You need to, just like OA, explain to them how they deal with flare-ups. So talked about activity modification, rest, potentially anti-inflammatory medications, and then a gradual progression back to activity, and then a good maintenance program once they get back to normal in terms of developing and maintaining strength, balance, and motor control of the area. How many times have you seen somebody that rehabs it up and then is right back where they started a couple months later because they didn't do anything to maintain? As far as conservative treatment, we talked about NSAIDs or a steroid burst. You could also try various different selective steroid or even PRP injections. One method that I've seen for people when I was in fellowship is, you get to the middle of the season and there is potential surgical management, but and you could also just rest, but you have to get them through the season. And what I've actually seen is up there, they were doing just a little bit of cortisone into the rectus insertion and the adductor insertion and the pubic symphysis, all three, just to calm it down, let it, get rid of the inflammation, let it get a little bit just cooled off and less painful. And then you're able to get them through the season and then address it more in the off season, whether that's with surgery or a more aggressive rest period. And then as far as conservative versus surgical, often the pain does come back with a return to play. 71% of athletes can relate a recurrence to a single event. So, they're striking a ball, they're going into trunk hyperextension or hip hyperabduction, and they feel this twinge sensation, almost like a groin pull. And then that is the onset of their flare up of their symptoms. Duration of chronic pain prior to a surgical intervention ranges from 3 months to 5 years. So this isn't like an ACL. You can play through this generally. So you don't need surgery right away, but sometimes ultimately you will. And that decision-making process often takes years even. As far as true hernias, I got a couple slides about this just to breeze through here, but there are actual hernias that are not sports hernias. You can have a direct or indirect inguinal hernia. I'm not going to go into a whole lot of depth here, but a surgical repair of a true hernia. One is called the Schuldeis, the modified Schuldeis, which approximates the transversalis fascia to itself. Essentially, they just sew it back all together to reapproximate the fascia and keep the actual herniation itself from herniating out. Then you have this modified Bassini, and then you have the Liechtenstein repair, which uses a mesh. This is actually something that you very commonly see. I've had several athletes that have had this done to them, prior to me taking care of them. I don't think I would ever recommend somebody getting a mesh treatment for this, but it's done relatively commonly, and that's typically site specific, surgeon specific. Sometimes that's how surgeons trained, and you end up with a surgeon that's like that, and that's what you get. Mesh repairs often have problems after the fact with continued nerve irritation and just continued pain. Not going to talk much about that. As far as surgical management of more of this quote sports hernia, there's a couple of different ones. Interestingly, we'll go through a couple of them briefly, but they all report that it works, even though they do completely different things. William Myers is up in Philadelphia, and he's a general surgeon and has developed this technique where he does a pelvic floor repair with or without an adductor release. It's open, it's an all suture repair, and his belief is that the pathology is purely muscular. And so he provides muscular reinforcement to the rectus abdominis and then the posterior wall of the inguinal canal. And his data shows a 96% return to full activity within 6 months. So that works, right? Separately, we have Ulrich Muscovec from Germany, who is a proponent of what she has deemed the minimal repair technique. And so she believes that the pathology is actually more weakness of the posterior wall of the inguinal canal and the transversalis fascia. And there is some weakness in that fascia that leads to a localized bulging of the actual inguinal ligament itself that then compresses the genital branch of the genitofemoral nerve within the inguinal ligament. And her goal is to decompress the nerve and then reconstruct the inguinal floor. She shows within her studies 80% complete pain relief at 2 weeks post-surgery. And then she has a paper with 87 pro athletes that returned to play within 4 weeks at 99% capacity. I actually had an athlete at DC United who had this procedure done while he was in college. He flew over to Germany, had it done because they were about to go into the NCAA tournament, and he had it done, and it did not help him. So he might be one of those 20%. So hip arthroscopy is another potential surgical management option for more. This is more for FAI. And so they can go in and repair the labrum and then take down any extra bone on the femoral neck with the cam morphology or the pincer morphology on the acetabulum. Sometimes you need a total hip arthroplasty. Sometimes things are so far gone that you can't really do anything else. And they just need a hip replacement. We try to do that. You try to put that off if somebody's in their 20s or 30s or 40s, but sometimes you can't avoid it. As far as return to play, conservative treatment for this, typically it's a 1 to 3 month range. The Muscovec repair is 2 to 4 weeks. The pelvic floor repair with Myers is 6 months. And a arthroscopic hip surgery where they go in and repair the hip labrum is about 6 months as well. So that's all I got for you. Any questions?
Hello. Okay. You go to the question tab. Give people a moment because I am curious too for their side of it since the app has changed a bit.
Here's one.
There.
Nadine.
Yes. Oh, and so it's easy for you to see now too. Good. It used to be like you had to have all these windows open and closed. And yeah, so Nadine is asking what the weight-bearing status post-repair of a labrum.
I actually don't know. I'm not a surgeon and typically don't take care of them post-operatively. It's 6 months return to play. I think generally it's 4 to 6 weeks of some partial weight bearing. But I don't know the specific intervals.
It is much more user-friendly that we can just toggle between these tabs.
I like it. I haven't seen the old one, but I like this.
So, in case there's other.
Nadine and I have covered some events here in Orlando together.
See, yeah, I will say some of the people who attend, I know them personally. Some of the people I've never met, but I will tell you that Nadine is definitely someone who regularly attends. So regardless of what time it might be of the day. Get some very regular attendees there. Lots of great questions.
I think you cover everything.
Question. Oh, okay. Okay, so Nadine asks, is that case specific?
Yeah. Arthroscopic labral repair with cam lesion removal and non-weight bearing for 6 weeks. Yeah, I mean that sounds.
Oh yeah, we'll read it out for the people who can't. So Devin said, I actually had an arthroscopic labral repair with cam lesion removal, and I was 6 weeks of non-weight bearing.
So it's probably about right. It's definitely a frustrating problem for people. I suffered from this when I was in college. I played soccer in college at Presbyterian College up in South Carolina, and had some problems with this, and it really took away my senior season. Here we go. I see a question up here. In closing, would you please summarize the athletic trainer exam and identify the findings that warrant referral? Yeah, I think it's just a thorough hip exam, essentially. So you do your classic range of motion, your fader, where you internally rotate and adduct, and your Faber, where you externally rotate and abduct. Scour test, where you're looking for the labrum. But then now we're adding all of these various different manual muscle tests to isolate your adductors versus your hip flexors and iliopsoas, and your palpation exams, palpating the adductor, palpating the pubic symphysis, palpating the rectus insertion, and just trying to further identify where the pain's coming from, so that you can lump it into one of these 7 categories as best as you can. Again, I don't think it's probably a good idea for you to examine the inguinal ligament, turn your head and cough kind of thing. But if that's something you feel comfortable doing, and go for it.
All right, well, wonderful. Well, thank you so much for speaking with the group today on all of the various potential pathologies that can occur at that sports hernia, groin pain, inguinal level. And thank you to everyone for attending. This was an excellent presentation. If you do have any future recommendations on speakers, if you want Dr. Mullner to come back and give us another great talk in the future, please go ahead and put that into the survey that goes out here in about an hour. And then if you are having any issues with our website, I know we've had some modifications to the website, so please don't hesitate to reach out to us. Yes, thank you again. Any last closing comments from Dr. Mullner?
Not at all. Thank you for all that you do with all of our athletes in Central Florida. Thank you so much. Have a good one.
Have a great day, everybody.